a few conditions, and we're going to see its related image and then talk about it directly. Not much of writing in this kind of lecture. So first of all, this is when your pinna appears like a cauliflower. We call it very commonly as, let me use another color, all right. So this is nothing but cauliflower ear. We call it cauliflower ear. Why does this occur? Why does the cauliflower ear occur? It's because of an hematoma. So let's say if we have an hematoma. What is hematoma? Hematoma is nothing but collection of blood between the perichondrium and the cartilage. So that is cauliflower ear. It happens because of the trauma usually seen in boxers, so it's also called as a boxer's ear. All right, apart from that, anything important that we are missing out? Definitely the treatment is going to be you incise this particular part of the pinna, and then you definitely drain the blood, drainage of the hematoma. So it's basically an hematoma. That being about it, after that, let's look at a very important disorder called as perichondritis. Well, this is nothing but perichondritis, and how do we know that? Because of the fact that perichondritis, let me just write it out here, it is perichondritis. How do you know? Because see, you could see a lot of inflammation, and inflammation is everywhere except perichondritis. Inflammation except the pinna. Why except the pinna? Because pinna is the non-cartilaginous part, and usually spared because of lesser involvement, whereas these other areas are mostly cartilaginous. What happens is the symptoms are going to be simple. You will have redness, so that's redness. You will also have pain, itching, not exactly itching, but hot pinna, definitely. And what is the cause? The most common cause is going to be Pseudomonas. Why does this occur? Well, this occurs actually post and a very important, let's say it actually occurs, let's say a traumatic condition, piercings, stuff like that. And how do you want to treat it? You want to do a simple treatment. You want to go for a third gen cephalosporin, or you could also go for some common new gen penicillins like ticarcillin and piperacillin. So piperacillin, or you want to go for a ticarcillin. That being about it when it comes to perichondritis. Let's say another very important disorder. What is this? This is nothing involving the pinna, but definitely these regions, there would be a pinna also, and the pinna would also be appearing something like this, and this is nothing called as erysipelas, which are seen in Streptococcus B or Streptococcus pyogenes pyogenes infections. And I just had to say it because it could be diagnosed as perichondritis, but if you would have areas of erysipelas out here on the nose and on the cheek, so definitely it's going to rule out a very important disorder called as perichondritis. Going next, jumping right next into a very important disorder called as, well, you could see there is certain amount of infection here. So this has to be otitis, but this is externa. And how do I know what externa is it? Obviously you need to examine, and you need to see the EAC, the external auditory canal. And when you see the EAC, if you can see something like this, these rounded bulges, so definitely it could appear something as folliculitis. And folliculitis is something that actually occurs only in the external auditory canal, and that too even in the cartilaginous part. Why in the cartilaginous part? Because the cartilaginous part is the only part of the external auditory canal which actually has the hair follicle, whereas in the bony part there is no hair follicle. What other things are you going to see? Obviously you're going to see pain, a lot of pain, because EAC has a good nerve supply, a good sensory nerve supply. uh, what else you could what else would the patient complain of? The patient would complain of pain on chewing or on regular jaw movements. That's simply because the canal is very well, is in close contact with the temporomandibular joint. And also the patient would complain of pain on movement of the pinna or even the tragus, or the entire pinna as whole. If they would be moved, obviously there would be pain, because the pinna is a continuation, the external auditory canal is a continuation of the pinna. So if the pinna moves, that means the cartilaginous EAC also moves, and there's going to be a lot of pain. What is a tragus sign? A tragus sign is nothing but, let's say we take this tragus and we press this downwards. Let's say we press this downwards. So definitely the patient is going to complain of pain, and usually see a tragus sign positive. It's going to completely tell you that it is a localized otitis externa or a furuncle. Now what is important is that what causes this disease? Obviously it's a staph aureus that causes this disease. And what do you want to use? You want to use simple penicillin, or you could use any of these treatments, antibiotics against staph aureus, usually penicillin. Coming next to another very important disorder, I do not really have a very important image when it comes to otitis, diffuse otitis externa. A diffuse otitis externa is very similar on presentation to our otitis externa of the furuncle variant. But what is different is that even the external auditory canal of the cartilages and the bony part is involved, uh, which makes the movements are very painful. The painful movements on chewing. Also, the only way you can actually see it is by seeing if the cartilaginous and the bony both are involved. And if both are involved, so the entire external auditory canal is edematous. The cause is going to be Pseudomonas out there. The cause is going to be Pseudomonas. So let me just write that down, because that's going to be differentiating. So Pseudomonas for diffuse, and it really appears very similar when you just look at the external view. It really appears very similar, and you're going to see certain amount of toileting that is to be done in the inferior aspect, more or less. And you should do a topical ear drops, steroid, usually antibiotics plus steroids if there is a certain amount of itching. Now what else is that you want to use? Antibiotics, as I told you, like ciprofloxacin or the ceftazidime, which is a third gen cephalosporin, and you want to continue with that. This year actually comes in a lot of swimmers. A lot of swimmers do complain of this particular disorder, because of the fact that swimming could lead to infection. Now how would it actually appear? Well, if you look in the endoscopy, the external auditory canal would appear edematous. So the lumen is really narrowed. So this would actually be the appearance in an otoscopy. All right. So that being about it, that is one more very important disorder. A very rare disorder, or something which I do not have an image about for, is Condrodermitis nodularis chronica helices. So Condrodermitis nodularis chronica helices. What that basically means is that there's a nodule on the helix. And what helix is, that if this is the pinna, this is your tragus, this is your lobule, could be attached, could be non-attached, whatever. So this is going to be your helix. Obviously there's going to be an anti-helix, there's going to be a conchi, there's going to be pyramidal fossa, blah 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 blah. But obviously there's going to be a nodule on the helix. This is a nodule which is on the helix. It's very painful, and it's seen in people of 50-year male. So if a 50-year male comes, you could keep that in a DD, a very important differential diagnosis. Apart from that, you could have cellulitis, you could have perichondritis. Perichondritis, again, as I have already shown you, it's by Pseudomonas. A lot of disorder out here is by Pseudomonas. Now coming to a very important disorder, a very important disorder which we all have seen. All right, let me just give you a heads up. All right. So this is something very similar to what what is this? Well, this is basically malignant otitis externa. Now this is something that needs a lot of attention and a lot of focus, because malignant otitis externa is again caused by pseudomonas. But what is the why is it so, aggressive? Because it's an elderly and an immunocompromised. Now what very important is that what is going to be the symptoms, signs, etc. Obviously you're going to have pain, you're going to have discharge, the patient is going to complain of hot, red, what about inflamed ear basically. And on examination you're going to see granulations. Why you're going to see granulation? Because it's malignant. There's a lot of necrosis that's occurring here, so you could see a lot of necrosis. There's a lot of discharge. This is a clear cut discharge that is seen here, and there's necrosis, there's granulations, there's necrosis, there is a cranial nerve involvement. Now this is something that I would want you to understand. Why? Because of the fact that this comes again into the basics of the external auditory canal. Before we go into the basic, before I go into the complications, I really want you to understand the treatment. The treatment is going to be the same as we've seen for the other pseudomonas, just that now you want to make them systemic if there's a lot of systematic, or if there's a lot of complications that are seen. And resolution has to be seen to determine the course of the antibiotic. So we need a lot of diagnostic tests to see the resolution. Now let me tell you about the complications that this particular disorder comes with. So malignant otitis externa. Now the complications are going to be cranial nerve involvement, and the other one is going to be skeletal or skull base osteomyelitis. Now what does that actually even have to do with the entire EAC? The thing about EAC is that if this is the ear and this is the cartilaginous and this is the bony, all right, there is going to be some fissures of Santorini, which allows the infection to go directly into the lower part, right? There are certain important fissures of Santorini that's present in the cartilaginous part. Now that allows the entire infection to spread. Now if it spreads, it obviously spreads into the skull base. It could spread into the skull base, or it could also go and involve the 9, 10, 11 cranial nerve. All right, so the earliest to be involved, also it could actually involve the 7th cranial nerve. Why? Because the parotid gland, let's say this is the let me come again. This is the auditory canal, and this is the fissures of Santorini, very close to the ear on the anterior aspect. Let's say this is the ear. Out here, very close to the ear, is nothing but the parotid gland, right? The parotid gland, and the facial nerve leaves the middle ear through a stylomastoid foramen. So because of the close proximity of the external auditory canal to the 7th cranial nerve, obviously your 7th cranial nerve could be involved, and even the 9, 10, 11 could be involved because of the jugular foramen that's present, the jugular foramen through which the 9th, 10th and 11th cranial nerve usually leave, and that is again present in the floor of the middle ear cavity, Therefore definitely we have to remember that the fissures of Santorini are very important foramens that allow the passage of infection into the skull base. Now if the infection presents into the skull base, which is very commonly seen, what do you want to do? You want to make sure that the skull base osteomyelitis is not seen. Obviously for the 7, 9, 10, 11 nerve, you could just do cranial nerve checks, or you could directly see the symptoms, right? And the 7, 8, 10, 11. But what is more important is, how do you check for skull base osteomyelitis? Well, to check for the skull base osteomyelitis, you want to do an early diagnosis. You want to do a bone scan, or you could also do a biopsy. Now when you do a bone scan, there's something called as a technetium 99 scan, which is again a bone scan that is checking for the osteoclastic activity or the osteoblastic activity, if it is increased or not. And osteoclastic or osteoblastic activities is usually increased when there is bone dystrophies or bone inflammations or bone repair going on. Also what you could do is you could do a CT scan to check for direct bone erosions, or what you could also see is you could see biopsies to check if there is any mitotic activity seen or not. Now if the mitotic activity is seen, you could also wonder if it could be a carcinoma of the bone, a chondroma, osteoma, vagera vagera, and stuff like that. And obviously I told you the management. If you want to check, if you want to stop the antibiotics, or if you think that this has come, so you want to keep the ESR in mind, because ESR is going to directly tell you how much of the inflammation has progressed or not. So this is very important, and the most important is fissure of Santorini that has been seen. Also out here you're going to have an anterior meatal recess. This anterior meatal recess could also be a very important landmark, because a lot of disease or a lot of disorders could be actually, stayed, would actually be, probably left over in this anterior meatal recess. So that's very important to understand. Now another important disorder that we should directly jump into is something called as a fungal or fungal otitis externa. Now definitely this is your newspaper water appearance. This is why it's called so. I do not know why, but definitely it's caused by a fungi called as by a fungi called as aspergillus. Now aspergillus is a very important fungi. It causes a lot of different disorders. You want to remember aspergillus niger and aspergillus fumigatus, these two important varieties of aspergillus that you want to keep in mind. Aspergillus niger is because of this black dots. Niger is giving this appearance of having a black dot. Now what are the features? Obviously you're going to have pain, you're going to have itching, you never want to. And how do you want to treat? You never want to give oil, because it actually promotes the entire development of the fungals. And what you want to rather give is, you want to give antifungal, like in the statin you want to give a cotrimoxazole, stuff like that. Also that is Aspergillus niger. Well, this is again a cotton ball appearance, so this directly points out to Candida. Obviously you can see a lot of pus around it, so this could mean that there could be a bacterial superinfection on top. It's usually common, but remember, obviously an otitis externa, 90% cases is a bacterial infection, and in 10% cases it is a fungal infection. This is viral otitis externa, or what we want to call as herpes zoster herpes zoster oticus. Now why do I know? Because of these vesicles that are formed. It's also seen with Ramsay-Hunt syndrome, where you see vesicles on the pinna. What you see is 7th cranial nerve involvement, and you could see ipsilateral facial paralysis. Obviously this is associated with herpes zoster virus. Nothing new, nothing old, everything the same. It can also involve the 8th cranial nerve by involving the auriculotemporal nerve, 8th cranial nerve, and apart from that, otitis externa hemorrhagica is due to influenza, where hemorrhagic bullae are seen on tympanic membrane and deep meatus. That is something that you should keep in mind. That's just an extra thing which I didn't really find a picture of, which I didn't really think it's very important to find a picture of. Now this is a very important disorder that's often mistaken as a fungal infection, and it's actually nothing but Keratitis obturans. Keratosis, sorry, not keratitis, but Keratosis obturans. What this basically means is that, let's say I will have to go back to the entire drawing part, and let me just really quickly tell you. Let's say this is your external auditory canal. These are your, out here you know that there is stratified squamous epithelium. Out here there are hair follicles, no hair follicles out here. So whatever happens is that there is the migration of the dead cells actually occurs in this. Now because the stratified squamous epithelium has a lot of keratin in it, the migration has to occur outside, and this is the natural process in a small amounts. Most of it is shed. But let's say if this is incorrect, and this is often with a triad of condition. Let's say there is bronchiectasis, there is also sinusitis, and there is keratitis or keratosis obturans. What happens is that there is obviously accumulation of your keratin out here. So your keratin is basically accumulated, and there's a lot of accumulation of keratin out here. And because of that, definitely what you're going to see is that the patient is going to have pain in the ear, and also is going to have deafness. Simply, how do you want to do it? You want to do a surgery. You just want to make sure you get this entire defective part out. All right. I think most of it we've covered. Collateral fistula is a very important disorder where the lateral external auditory canal does not fuse with the medial, and because of that, if this is the pinna out here somewhere, you would have a collateral fistula. Nothing, just a developmental defect, collateral fistula. That is a very important development defect, and there is one more called as cryptosia. Cryptosia is basically when the upper part of the pinna is usually fused with the skull. So your pinna is something like this, and the upper part is directly just fused with the not skull, but rather I would say as with the scalp. Correct. It's just a developmental disorder. Nothing, not a big hampering factor when it comes to hearing. That's about it. The diseases of the external ear.